Thank you, sir. Good morning. I'm going to talk about the common clinical case with sort of unusual clinical presentation. Our patient is Mars 10, 7-year-old child, present with a history of fever and low stool since October 2nd. And he has fever persist more than 2-week duration, and on examination he has fever, and other than there's mild hepatosplenomegaly, there were no lymphadenopathy or any other significant clinical finding. And you can see his fever chart. There's continuous fever for more than 2-week duration. And moving on to the investigation, his initial investigation shows severe pancytopenia with WBC count of 1 with HB6 and platelet 33. At this point, our main differential diagnosis was whether there is any bone marrow pathology or whether there is pyroxia of unknown with unknown origin with coexisting hemophagocytosis. So we proceed with the bone marrow aspiration. However, bone marrow aspiration and trephine biopsy shows the evidence of infection. There is no evidence of marrow infiltration, and the fibrinogen level is marginally low. And his liver function test mildly elevated with CRP of 99 and triglyceride mildly high, and serum ferritin level is 2900, and ultrasound shows the enlarged liver and the spleen. And his virology testing, including dengue, NS1 antigen, and antibody negative with the EBV, hepatitis AB, were negative. So, microbiology investigation, his SAT test, not that much significant, and blood culture came as negative. However, the bone marrow culture came as positive. So, what is neutropenia? Neutropenia is a reduction of neutrophil count to standard deviation below the mean value. So, usually it should be less than 1.5. It could be a case of isolated neutropenia or could be a pancytopenia like in our patient. Depending on the severity, it could be either mild, moderate or severe, and in pediatric age group, the reference ranges are a little bit different. And the mechanism also vary. It could be either impaired production with the bone marrow suppression, especially in the case of leukemia, or bone marrow infiltration by solid tumors, or could be impaired release from the marrow, or could be increased destruction, especially in the autoimmune causes, or could be due to hypersplenism-like causes. So, as I said earlier, the causes for pancytopenia could be either reduced marrow function or bone marrow aplasia or marrow infiltration by acute leukemia or even other solid tumor or even tuberculosis, megaloblastic anemia, PNH and other causes. And isolated neutropenia most of the time present with congenital causes like severe congenital neutropenia, cyclical neutropenia, Cosman syndrome and other congenital causes. But you have to remember, even with the leukemia and bone marrow infiltration, still the isolated neutropenia also a presentation. And also with infection like HIV, hepatitis A, B and bacterial infection, still the patient can present with isolated neutropenia. So in such cases, when you are suspecting any bone marrow pathology, we have to proceed with the bone marrow aspiration. It is done as a procedure under the local anesthesia, little bit invasive procedure. So prior to doing bone marrow aspiration, it is important you to remember that there's a special request form. So you have to fill the request form properly with the examination finding and the available investigation. And also it's important to mention the suspected differential diagnosis, because in usual setup we are taking sample only for the aspirate, that means for the bone marrow morphology and for the flow cytometry. But if you require the additional sample, you have to provide the detail. Then only we can take the sample and you have to send with the appropriate container, because you can't do it repeatedly. It's a little bit cumbersome to the patient. So in normal setup, We are taking bone marrow aspirate sample for EDTS bottle and for the flow cytometry. But in case if you are suspecting any leukemias or lymphomas where you require any genetic testing for the karyotyping, we are taking sample for the sodium heparin tube. And if you require any microbiological sample, that's mean for the TB culture or bone marrow culture, you have to request. Otherwise, we are not usually taking. So you have to remember before sending patient to a bone marrow aspiration, the clinical detail and the request, the require additional samples you have to make sure. So rest of the presentation will discuss by microbiology.
So, what can we do with infections and neutropenia? Infection, of course, can be caused by. I have tried some things. It's not coming here. I'm really sorry. Tried the last week's workshop, but my writing has gone away. Anyway, so infection can be caused by neutropenia, and neutropenia can be caused by infections as well. And apart from that, drugs can cause neutropenia. So in the blank box, it should be neutropenia. So I don't know what will happen further. So viral infections present in neutropenia. These are the common viral infections where you can get neutropenia. That is, as earlier discussed, HIV, infectious mononucleosis, cytomegalovirus, hepatitis A, viral exanthema like measles and all, and respiratory syncytial viruses and so on, and including, of course, dengue. So there are viral infections which can cause neutropenia, and there are bacterial infections also which can cause neutropenia. Typhoid is one of the topmost infection, and apart from that, Shigella, brucellosis, tularemia, and tuberculosis can cause neutropenia as well. So typhoid fever, severe systemic infection, as we all know, and sustained fever and abdominal symptoms. They are the main symptoms we get, and where you can get the thrombocytopenia, anemia, and even more frequent. You can get leukemia as well. So in typhoid, you will expect anything like pancytopenia or neutropenia. And in this case, is the patient infected because of the neutropenia? That was our question. Or is the patient neutropenic because of the infection? Or whether they had different reasons. So, to find the cause, you had to do blood cultures. But blood cultures were negative. So, you can see that because the child has been unwell for 14 days, and obviously, although we couldn't find out, the child must have been taken to several GPs, where they must have given antibiotics, and obviously, blood cultures will become negative if the organisms has been sensitive. And urine cultures done, negative. Stool cultures done, negative. So what is the next thing? They have done SAT as well, although we never recommend SAT because we don't know the our levels actually, because we don't do surveillance studies to check our levels. So that we can't say, we can't say that's positive with small titers like this. So anyway, but if you do two like acute stage and convalescent stage 2 samples, and if you see fourfold rise or something, you can diagnose, but that will help only epidemiology, not the treatment, because convalescent means patient is well. So to exclude malignancy or infection, they correctly have done bone marrow biopsy, and because the reasons for bone marrow biopsy, because the unexplained leukemia and fever, unknown origin. So luckily, they have sent the microbiology sample, because most of the time we don't get biopsy samples, and we are unable to help in that case. So bone marrow biopsies also we proceed as blood cultures. We take into the blood culture bottles and incubate and we get the positive results. So what we got, Salmonella typhi in bone marrow culture. That was really good to treat the patient. Very helpful because we have grown salmonella on the agar plates and we could see on the next smear and we could do the biochemical test, very typical, and of course, and we could do the serotyping as well, where it was confirmed that it was salmonella typhi. And then fever. After getting admitted to the Kandy hospital, although they have started ceftriaxone, the pediatricians were getting worried because fever is not settling. So if we didn't have this diagnosis, salmonella, because if it was salmonella, we know fever doesn't settle that easily. That could take more than 5 days, minimum 5 days, with correct treatment to settle the fever. But what you see, clinical child was getting better, he could eat and play and happy and comfortable. So then of course with this diagnosis we can relax and wait. So and the other thing of course, salmonella is one of the infections where you can have a good yield from bone marrow cultures than blood cultures. So if you really suspect salmonella, if you really suspect typhoid, if you get your blood cultures negative, it's better to do a bone marrow biopsy for culture. So it was very interestingly sensitive to all the antibiotics, and although the child was on ceftriaxone, we could have stepped down when the child was well and to be discharged. It was sensitive to all. To take home message, do you suspect the infection? Take blood cultures before antibiotics. And other plus minus other cultures depending on the site of infection. It could be urine because sometimes we get referrals querying urosepsis but without urine culture. So it's very important to do the particular culture where you suspect the infection. Pneumonia, sputum cultures. We don't get very positive good sputum cultures, but you can do. And if you suspect meningitis, CSF and so on, an infected wound, pus aspirate or wound soap after cleaning the wound with normal saline. And further on, is investigating for PO or blood cultures, at least 2, because it's PO. We have to find a cause somehow. Negative blood cultures, and it's better to do a bone marrow culture. Thank you.
Thank you, Madhumanee and Danushka, for that very interesting case. I am sure pediatrician must be very thankful to both of you for your active role played in this case. The case is open for questions.
Two questions regarding the bone marrow biopsy. What is the platelet level you consider before doing the bone marrow biopsy, and use of steroids and doing the bone marrow biopsy?
There is no absolute platelet count. Even with the platelet zero, we are doing bone marrow because it is done under local anesthesia. And second question. Yeah. So if we are suspecting a case of leukemia and lymphoma, especially the ALL and the lymphoma cases, prior to starting the steroid, we have to do the bone marrow because as a treatment for the leukemia and lymphoma, we are using the steroid. In such cases, better to do the bone marrow extraction first. Other cases, it's not that much problem.
In the absence of any more questions, we will move to the